Welcome back to the deep dive. Today, we are opening up a topic that is, well, immense in its scale and deeply personal, the disorders of thought, emotion, and memory. Our sources tell us that the prevalence of mental illness among U.S. adults is staggering. We're talking about 17.9%. That's nearly 1 in 5 adults experiencing these challenges yearly. It's huge. Our mission today is a rigorous deep dive. It's based entirely on a key chapter from Porth Pathophysiology. We're really synthesizing the complex mechanisms behind these altered health states. We're focusing not just on, the symptoms, but on the how and the why, connecting the underlying biology, the specific molecules, the cellular stuff, directly to what you see clinically. We want you to walk away understanding the engine that drives these conditions.
And that biological context is absolutely critical. These disorders, ranging from severe mental illness to substance use and neurocognitive decline, they're characterized by these imbalances of thought, mood, and behaviors that profoundly interfere with daily functioning. And while diagnosis is guided by the DSM-5 standards, which are established, what's really fascinating here, I think, is moving beyond just labeling symptoms. We're exploring the fundamental roots, the complex interplay between biological, psychological, and environmental factors. Okay, let's unpack this.
Yeah, let's start with the scope. The numbers are pretty sobering, confirming the size of the problem. 1 in 5 Americans experiences a psychiatric disorder in any given year. That's what the data says. But if we look at the trajectory, the sources highlight something really critical. 50% of all chronic mental illness actually begins before age 14. That tells us these conditions are often developmental, right?
It absolutely points toward development, yeah. And we also have to look at the pervasive connection between mind and body. It's unavoidable. The sources emphasize that 30% of people with a physical disorder, like, say, diabetes or heart disease, they have a coexisting psychiatric disorder. So to understand this deep crossover, we really rely on the multi-causal model, which means you have to look at everything simultaneously. Biologic factors like genetics, infections, maybe toxins, alongside psychological factors such as sustained stress or early loss, and of course environmental factors too, things like cultural demands or dysfunctional family dynamics.
That interaction where nature meets nurture, it brings us squarely to the stress diathesis theory. Could you walk us through that core concept?
Certainly. So this model, it basically posits that you carry an inherited predisposition. That's the diathesis, sort of the metaphorical gunpowder, if you like. And then the environmental pressures, the stress, they act as the match that lights it. The theory emphasizes that the long-term consequences of, disturbing events depend heavily on existing factors, things like your age, your coping skills, and crucially, your pre-existing neurophysiology.
And the most compelling physiological example of this stress diathesis link, the one that really connects trauma to permanent biological change, it seems tied to adverse childhood experiences or ACEs. You mentioned these experiences fundamentally change the body's wiring. Can you walk us through the specific epigenetic mechanism the sources highlighted? Because that sounds key.
It really is one of the most important takeaways from this material, I think. Trauma, especially early adversity like abuse or severe neglect, it causes these long-term emotional, immune, and metabolic changes. Why? Because the stress response system itself is permanently altered. And the mechanism for this permanent change is methylation. So in simple terms, early adversity can actually alter the DNA in the brain through methylation. This is a process where these little chemical tags called methyl groups, they affix themselves to genes. Now, if they attach to genes that govern the production of stress hormone receptors, they essentially turn those genes off, like flipping a switch. This prevents the brain from regulating its response to future stress effectively. It just can't dial it down properly. And this leaves the individual predisposed not only to major depression, but also to cardiovascular disease. We see higher inflammation levels, often measurable by markers like C-reactive protein. This connection fundamentally changes how we view psychiatric risk. It's not just psychological, it's measurable inflammation and, genetic modification.
That insight is truly essential. Okay, so if methylation is disrupting the structure, how do these dysregulations play out in the actual moment-to-moment function of the brain?
Right, what comes down to information processing. Normal brain function relies on these synchronized neural networks. Psychopathology essentially is the result of dysregulation that disrupts these networks, and it impairs neuroplasticity. That's the nervous system's amazing ability to change its structure and function in response to experience.
And the amygdala, the brain's sort of alarm center, seems central to this process, doesn't it?
It is very central. Intense arousal of the amygdala strengthens the memory imprint of a traumatic or highly stressful event. It makes it vivid, unforgettable. But here's the paradox. That same intense arousal makes the experience less likely to be processed coherently by the rest of the brain, particularly the prefrontal cortex, which normally modulates emotion and gives context. So the overwhelming emotion kind of impairs the coherent storytelling aspect of memory, becomes fragmented.
And all this action is mediated by key neurochemicals, those messenger substances we call neurotransmitters, that manage our endocrine and behavioral responses to stress. We need to distinguish clearly between excitatory and inhibitory here, I think.
Exactly, that's fundamental. Excitatory neurotransmitters, like glutamate, they increase the probability that the target cell will fire an action potential. They promote wakefulness, energy. Think of it as the gas pedal. Conversely, inhibitory neurotransmitters like GABA, they act as the body's natural tranquilizer. They're the brake pedal. They slow things down, induce sleep, promote calmness, even a slight imbalance in this complex cocktail, which also includes acetylcholine, ACHE, and norepinephrine, NE, which can actually be both excitatory and inhibitory, can lead to major pathology.
Speaking of pathology and brain structures, let's quickly review memory classification before we move on. It's important context. We classify memory into immediate, which is just seconds to minutes, recent, which is minutes to days, and remote or long-term memory, which lasts for years and actually involves structural changes in the synapses.
Right, and the key structural players you need to know are the amygdala, the hippocampus, the prefrontal cortex, and the cerebellum. And if we circle back to trauma for a second, we find a direct pathophysiological link here. Significant trauma can actually reduce the size of both the amygdala and the hippocampus. And when the hippocampus, which is key for integrating memory, shrinks, it impairs your ability to integrate those traumatic memories into a coherent, organized narrative.
Right.
You might be left only with fragments, images, sensations, without the words to really make sense of the experience.
Okay, so if the structures and chemistry are the foundation, let's look at how they manifest in specific conditions. If Section 1 represented the sort of building blocks of psychopathology, let's transition now to the clinical results, starting with schizophrenia. This is a chronic, often debilitating psychotic disorder. It affects about 1% of the population, with onset typically between ages 16 and 30. It's fundamentally a break with reality, featuring things like delusions, hallucinations, impaired reasoning. And the diagnosis requires 2 or more of these psychotic manifestations lasting a full 6 months.
And to really understand the symptoms, the sources require us to separate them into 2 main groups, positive and negative symptoms. This distinction is vital because it explains some of the clinical challenges in treatment.
Okay, so the positive symptoms are the presence of abnormal behaviors, right? Things like hallucinations, often hearing voices, delusions like the belief people are watching them, or maybe grand visions of power. Plus, disorganized thought, incomprehensible speech, sometimes sensory overload, where normal stimuli like sound or color become painfully intense. And these symptoms are generally more responsive to medications, I understand.
That's generally true, yes. But then you have the negative symptoms. These reflect the absence or a profound lack of normal behaviors. Things like lack of emotion, what we call blunted affect, poverty of speech or alogia, apathy or avolition, lack of attention. These are the symptoms described in the source material as being the most difficult to treat because they represent a fundamental loss of function, and they often persist even between acute psychotic episodes, causing severe disability.
So what's the schizophrenia neurophysiology? What's underpinning this profound deviation?
Well, it's highly complex, as you'd expect. We definitely see dysregulation involving dopamine, GA, and serotonin, 5-HT. That's what most medications target. However, we also find decreased glutamate activity specifically linked to dysfunction of the NMDA receptor. That's important. And deficits in GABA, the inhibitory transmitter. Structurally, neuroimaging consistently reveals things like excessive loss of cortical gray matter, abnormal thinning of the cortex, and a sort of compensatory enlargement of the lateral and third ventricles in the brain. It's a disease that really attacks both the hardware and the software, so to speak.
Okay, next let's transition to mood disorders. These carry a 9.5% prevalence rate in the US, so quite common. Our sources specifically focus on major depressive disorder, or MDD. What are the key criteria that separate clinical depression from just, everyday sadness?
Right, that's a critical distinction. For MDD, the symptoms must be present most of the day, nearly every day, for a minimum of 2 weeks. And they have to interfere with functional activities. The hallmark symptoms include things like a profound loss of interest or pleasure in previously enjoyed activities and hedonia. Also, feelings of worthlessness, significant changes in appetite or sleep patterns, fatigue, difficulty concentrating, and sometimes recurrent thoughts of death or suicide.
And just for context, maybe we should briefly mention dysthymia, which is chronic but perhaps milder depression lasting at least 2 years, and premenstrual dysphoric disorder, PMDD, which is related to severe psychological issues tied to hormonal fluctuations before menstruation.
Good point. And if we connect the pathophysiology of depression back to the bigger picture we discussed, the sources really highlight that depression is strongly linked to inflammation. You can often measure high C-reactive protein. This is key. It tells us depression isn't just in the head, it often looks like a systemic inflammatory disease. It's also linked to HPA axis hyperactivity. That's the stress response system. This HPA axis overactivity often stems from chronically elevated cortisol levels, particularly if there's early life stress. And then there's the classic theory, the monomonergic hypothesis. This attributes depression to decreased levels of those key mood regulators, serotonin, 5-HT, norepinephrine, NE, and or dopamine, DA, in the synaptic cleft, the space between neurons. Low GABA levels are also frequently found, which removes that brake pedal on the stress response system.
Okay, switching gears now to the most prevalent group of psychiatric disorders, anxiety disorders, affecting a huge 18.1% of people. This group includes a whole range, doesn't it? From generalized anxiety disorder, GAD, and phobias, to the profoundly physical experience of panic disorder.
Yeah, and panic disorder is particularly acute. It often presents a real clinical challenge because the physical symptoms are so severe. It involves these recurrent, unexpected surges of intense fear or discomfort, and they're accompanied by strong physical symptoms: palpitations, sweating, trembling, shortness of breath, chest pain. It's incredibly difficult sometimes to differentiate this from serious medical conditions like a heart attack, which is why these patients frequently end up in the emergency room.
And biologically, what's the anxiety neurophysiology picture?
It seems to involve the underaction of the serotonergic system, which usually helps keep things steady and calm. And, at the same time, a significant overactivation of the adrenergic or sympathetic nervous system, that full-throttle fight-or-flight response. And that intense physical fear characteristic of panic attacks is specifically tied to a hyperactive amygdala. It's just constantly sounding the alarm when maybe it shouldn't be.
Okay, we also need to pause and mention obsessive-compulsive and related disorders, OCRDs. The DSM-5 actually separated these from anxiety disorders, right? Because the mechanisms seem different.
That's right. These are characterized by distressful, uncontrollable thoughts. Those are the obsessions. And repetitive, often ritualized behaviors that the person feels driven to perform. Those are the compulsions. And this category now also includes things like body dysmorphic disorder and hoarding disorder.
And neurophysiologically, what's linked to OCRDs?
They seem linked to a specific circuit disruption involving the orbitofrontal cortex, the cingulate cortex, and the basal ganglia. It's like a loop that gets stuck. And recent research points quite heavily to the role of glutamate signaling in the pathology of these sort of uncontrollable thought patterns.
Right. Finally, in these psychiatric categories, we should touch on substance use disorders, SUD.
Yes, absolutely. The central issue here is the preoccupation with seeking and using the substance despite negative consequences. The etiology is complex. We know there's a strong genetic component, perhaps up to 50% of the risk is inheritable. But the central mechanism really across all substance classes is the hijacking or activation of the brain's reward system, specifically the mesolimbic pathway.
And this reward pathway works primarily through dopamine, doesn't it?
Exactly. Dopamine is key. Substances basically facilitate dopamine transmission in this pathway. This gives the substance and the cues associated with it powerful incentive and highly reinforcing properties. It feels good, so the brain wants more. For example, cocaine and amphetamines work, in large part, by blocking the reuptake of dopamine from the synapse. This dramatically prolongs its effects, causing that euphoria. Alcohol, on the other hand, is a bit messier. It mediates its broad effects by interacting with both the inhibitory GABA system and the excitatory glutamate system simultaneously.
Okay, let's pivot now. We need to cover disorders of memory and cognition, what the literature now calls neurocognitive disorders, or NCDs. This is the precise term replacing dementia in scientific contexts. And cognition itself is basically how sensory input is transformed, stored, retrieved, and used.
And it's really crucial here to know the difference between NCDs and normal cognitive aging. While normal aging might involve a gradual slowing, maybe in learning new information or processing speed, like occasionally forgetting where you put your keys but figuring it out later, that slowing doesn't really affect your functional abilities day to day. NCDs, however, involve a persistent and severe decline in mental function. Gets to the point where it seriously interferes with daily activities, like managing finances or personal care.
And the elephant in the room here, unfortunately, is Alzheimer disease, AD. It's the most common NCD, accounting for maybe 60% to 80% of all cases. It's insidious in onset, it's progressive, typically allowing maybe 8 to 10 years of survival after diagnosis. Clinically, the hallmarks are that severe loss of short-term memory, difficulty with language, and often profound behavioral changes later on.
And the pathophysiology is highly distinct. You really must be able to visualize this. As the source material highlights, you need to picture the structural changes. Massive cortical atrophy, shrinking of the brain cortex. It's particularly severe in the parietal and temporal lobes. You can see this on scans, like in figure 18.3 in the text. But the classic microscopic findings, the things you'd see under a microscope, are the true identifiers. First, neurofibrillary tangles. These consist of abnormally hyperphosphorylated tau protein. Tau normally stabilizes microtubules, the neuron's transport system. But when it gets hyperphosphorylated, it clumps together into tangles inside the neuron, essentially clogging and killing its internal transport system. And second, amyloid plaques. These are dense aggregates of a protein fragment called amyloid beta peptide that accumulate outside the neuron. These two proteins, tangles inside, plaques outside, are the signature drivers of neuron death in Alzheimer's disease.
Okay, let's briefly detail some other critical NCDs for comparison, as they each have a unique trigger or presentation.
Right. First, there's delirium. This is an acute, fluctuating confusional state that develops rapidly, often over hours or days. It's almost always triggered by an underlying medical condition. Think severe infection, uncontrolled pain, dehydration, or certain medications, especially in the elderly. The absolute key here is that if you identify and eliminate the underlying cause, the delirium typically resolves. It's reversible.
Then we have vascular NCD.
Yes, this results from brain injury due to ischemic or hemorrhagic damage. Basically, strokes, either a series of small ones, Lecanar infarcts, or larger vessel strokes. Because the damage is often focal, meaning in specific areas depending on the stroke location, the early domains affected are often complex attention and executive function, things like planning and decision-making rather than just memory initially.
Okay, and next is the spectrum, including Parkinson's and Lewy body disease.
Right. The underlying pathology here is linked to aggregates of a different protein, alpha-synuclein. These aggregates form what are called Lewy bodies. In pure Lewy body disease, LBD, these Lewy bodies accumulate primarily in cortical neurons, those involved in thinking and memory. This leads to some distinctive early symptoms, dramatic fluctuations in alertness and attention, kind of waxing and waning confusion, and recurrent visual hallucinations, which are often quite detailed, involving people or animals that aren't there.
And finally, let's cover the genetic and substance-induced categories quickly.
Okay. Huntington disease, HD, is a devastating genetic mutation. Autosomal dominant, it causes a profound decrease in the inhibitory neurotransmitter GABA, particularly in the basal ganglia, a brain region crucial for motor control. This lack of inhibition leads to an increased release of the excitatory neurotransmitter glutamate, especially to the frontal cortex. And this imbalance manifests as the characteristic motor symptoms like chorea, those uncontrolled, jerky, dance-like involuntary movements. Then we have Wernicke-Korsakoff syndrome. This is a specific substance-induced NCD resulting from chronic alcoholism. Crucially, it's caused by a severe deficiency of thiamine, which is vitamin B1. Chronic alcohol use impairs thiamine absorption. Clinically, this presents with quite discrete memory impairment, especially difficulty forming new memories, and often a tendency toward confabulation, where the patient unconsciously creates plausible but false memories to fill in the gaps caused by the amnesia.
Wow, okay, so bringing this all together.
Yeah, and to synthesize everything we've covered, what's really fascinating here is how the mechanisms connect across these seemingly different disorders, nearly all of them, whether we classify them as purely psychiatric like depression or neurocognitive like Alzheimer's. They really boil down to this complex interplay. It's genetics, that inherited vulnerability, environmental stress acting upon it, and the precise dysregulation of key neurotransmitters. We keep seeing the same players, DA, 5-HT, GABA, and glutamate, and how they act on those central brain structures like the amygdala and the hippocampus. It's a recurring theme.
Absolutely. We've clearly seen that symptoms are never just in the head, are they? They are tied to measurable, tangible pathophysiological processes. Everything from DNA methylation caused by early trauma to specific protein tangles and plaques that visibly damage and kill neurons in NCDs. And knowing these mechanisms is so important because it helps clinicians frame interventions, not just pharmacologic ones, but also psychosocial approaches that actually target the underlying biology, which really raises an important question for you, the listener, to consider as you apply this knowledge. Given the strong evidence linking early life trauma, those ACEs, to measurable physical changes in the brain's stress response machinery, we're talking actual DNA modification and inflammation.
No.
How might future public health interventions focus not just on treating adult symptoms, but on fundamentally strengthening resilience and supporting optimal neurobiological development right from childhood? Something to think about.
A really profound point for reflection. Thank you for joining us on this deep dive into the altered states of thought, emotion, and memory.
Indeed. Until next time, keep digging into the details.